Thank you. Thank you so much. First of all, thank you so much for the invitation and the possibility to speak among these incredible speakers of the morning session. And I want to show you today something about prosthodontics. We heard a lot of implants, bone, loss of bone. How can you manage your surgical part? And thanks to this wonderful lecture of Dr. Kim, now I want to bring you more into the prosthetic part. And I want to show you the possibility of the digital workflow, the digital world. And this is something very interesting. And at the beginning, I want to do a statement. And we want to prove the statement later on. Digital workflow, intraoral scanning, is simple, it's safe, it is successful, precise, and predictable. So this is a big promise I will give to you. So we will prove it now. And before we see some crowns, we will have a look into the technician. So what about the transfer technique of intraoral scanners? They're completely different to the lab scanners. Maybe you know some. I don't want to bother you, but there are three kinds of technician. It's triangulation, it's a confocal laser scanning, and it's wavefront sampling. These are three steps you can use, depending on the camera system you're buying, to translate the situation of the mouse into the computer. The next thing, if you decide to buy an intraoral scanner, you have to have a look on the wand. This means on the camera. There are different sizes, and the size is always driven by the technique inside the wand or the evolution of the scanner, and you will see it if you use it in the patient mouse, because outside of the mouse, every size is easy to use on a model. It's important to think about. But the real important thing is that we have to transfer the information of an implant to the CAD/CAM system, to the software, and there we are guided by a scan body. And there are some secrets about the scan body. So the first thing is, you can see I highlighted a little bit, the digital impression offers a valid alternative to conventional impressions for single and multi-unit implant-supported restorations. So after this study, we know, or there are a lot of studies, we can use it because intraoral scanners on teeth, on crowns, inlays, bridges are proven very well. So just remind the CEREC system, it's very easy now, it's very common to use. But implantology is a little bit different. The next thing, the precision of an intraoral scanner decreases with an increasing distance between the scan bodies. Normally, if you do just one single implant or a bridge, 3-unit bridge, it's not a big problem. But I will show you later two cases of an edentulous full arch where we scan 6 or 8 implants. Then the precision is very important for your technician, even for us. Yet the scan body visibility, observer experience, and scan length remain relevant factors. So not everything is easy, and precision is not staying at the same level depending on what you're scanning in the mouse. These topics are very important to keep in your mind. So, but let us face a little bit of the biology. We heard a lot of biology today, and mostly it's depending on the way you did your implant, you positioned your implant in the bone, and how you treated your gingiva, your soft tissue. But also the prosthodontics can do things very well or not so good with their crowns or their restorations. And there's a lot of factors affecting the success of an implant, the outcome of an implant. For me, doing crowns and bridges on the implants with digital scan, only these things are very important. The prosthetic, you want to be cemented or screwed or platform switched. As we already heard this morning, the CAD/CAM system, the possibility you have, the process, or the load is very important. to keep something successful over the years. We don't have to forget this. And the material of the abutments. So do we want to have something fully milled out of zirconia, fully milled out of titanium? Do we want to do something like a combination titanium and zirconia? It's very important to have a look on it. And for me, the biggest eye-opener years ago was when I looked into the literature and think about how often you're screwing on your implant during your healing period. And you can also ruin the bone around your implant in the healing period, even as a prosthodontic. Not only the oral surgeon can do this, you also can do this. So there's some interesting studies that there is a statistically significant reduction of the horizontal bone remodeling if we screw on the implant. So normally if I ask you, what do you think, how many numbers of screwing you have, you always will be wrong. So think about an implant. It's healed transgingivally, so you put in the implant, put on the healing screw, and suture it, and let it heal for some months. Then you screw off the screw, you screw in the impression coping, you screw off the impression coping, you screw in the healing cap. Okay, now you've done the impression. The crown has been built by a technician. Then you screw off the healing cap and you screw in the abutment. So normally you're doing 6 times. And then you're quick because you haven't had an appointment to try something in. So this is very, very often. So have a look on the literature. We see there are some more problems that compromise the mucosal barrier and the bone. You drive them down, even if it's just 1 millimeter. And we have a lot of bone loss. So this is very important for you to know. And then if you compare 1 versus 4 component changes. 4 component changes. I told you 6. You're doing 6. So how can you manage 4? This is very important for you to know. Not to screw too often. And by the way, if you're using platform switching, the first component screwed on the implant should be smaller or should be switched. Not later, not doing, I'm just using the normal gingival healing cap and later I'm using a small abutment. This is not platform switching. So you have to think about these facts. And if we have these facts in mind, we got a problem. This leads us to a certain problem. 6 times changing. How to minimize this number? It's not easy. Okay, we have to reduce the numbers of screwing on an implant. We have to create an ideal emergence profile with our prosthetic. And what is the ideal time for definitive abutment? At the time of surgery would be great, but how to do? Later, after healing, when is the ideal time? And therefore, we have this workflow path through, I don't know how you can call it, but you have to decide, if you do an implant scan in the mouse, not in the model, in the lab, in the mouse, do I have to change the scan body? Then you're still at 6. You can change out scan body against impression coping. It's the same. You use 6 times screwing on the implant. Or do we keep the scan body because the scan body is something like a healing cap or healing abutment, however you call it. Then you can reduce the number of screwing. Or do we use something like 1 abutment at one time? This means at the time of surgery. No screwing anymore. So this is which way to go. And at the moment I would say this is the way of today. You're working. So I want to give you 3 answers, not only questions. 3 answers to this problem or to this question. The first answer would be R2 gate. we had an incredible lecture of Dr. Kim to see what you can plan right before your first incision, right before you put in the implant into the bone. Would be a possibility. A scan abutment, which help us, would be a possibility, or something called like a scan healing abutment. And you know, by using the word scan healing abutment, there is something hidden, there is a solution hidden in this topic. Okay, let's see. Because we want to come from the digital scan somewhere to this. And I don't know if you know what your technician is doing every day. Normally we don't see this. These are some screenshots of the technician. He's doing his work already digital. It's not us, it's him. For him it's quite normal. So these are pictures how a digital tooth can grow and can be produced. This is only the design, it's virtual, it's not real. After this, the crown, the abutment get be milled, and then it's real. But we have to plan it. And the question is, do we plan it right in front, the operation, or later? So, R2 gate is the thing I don't want to talk about too much today, because we already heard a lot of it. This means we are planning right from the beginning. And trust me, it's not only for the full edential case. It's nice to have an R2 gate for 1 implant or 2 implants. It's easy to do. It reduces your time of surgery. But coming back to the intraoral scanner, to the scan bodies. This is something, a perfect choice for the digital workflow, I call it. It's a scan abutment. Most of you know it from the lab side. It's nearly the same. You bring it, you screw it on the implant in the mouth, and you can scan it. And with the help of this scan body, with these marks, you will transfer data like diameters, position of the internal hex, position of the surrounding gingiva. You will transfer it to the CAD/CAM system. This means we have this way. There are some pros and cons. Well, we still have to screw 6 times, but we can be more precise. And we can do it at any time we want. So this means in pictures, you drill a hole, you bring in the implant with a high insertion torque. I love this high insertion torque, believe me. And then you bring in this healing cap, healing abutment, whatever you call it, and you suture it and let it heal for some months. And afterward, you will change it. And if you change it, this is healed, you change it against the scan abutment, and this is a picture of the intraoral scan. Now you see everything. It's more precise than your impression. Because to be honest, if you have a look on your impression, yeah, it can be good or not. Mostly the technician has to decide if it's good or not. But then the patient is away, out of your office. He has to come a second time. Here I can control right at the moment, and I can see what to do. And believe me, we're not milling everything without any model. When I started the digital progress, 9 years ago, we just had the chance to mill a crown, to mill abutment just for 1 implant or for a bridge without any model. Because the secret behind the model factoring is, do you have a lab analog for your printed model for your implant system or not? But not everything can be done milled without any model, model-free. That's not possible. But not every model which can be printed or milled can keep a lab analog. That's very important to know. So now we can use, today there are some companies producing these models, and you see it's like your normal cast you're using. And you can produce everything you need like you do it in your regular daily business. That's the thing. And for me, the emergent profile is the most important thing we can create for a successful implant restoration. Because I think the prosthodontics are the keeper, the keeper against peri-implantitis. You are the last wall to defend your implant of your patients. You're the one, because you're creating your crowns. And you see, this is a perfect emergent profile, and you can screw it or you can cement it. Depend on you. And if you screw it, you can cover this whole, paint a little bit brown on the crowns, no problem. It's still the same, but it's digital based. It's very important. It's more precise. Or even in not so beautiful cases like this, it's a periodontal patient. So screw it out. This is the situation if you put it out. Measure. Even we do the ISQ. I can warmly recommend this to you to be sure that the implant you will use is safe. This is a scan body. This is another intraoral scanner. The first was the true definition. This is an iTero. You can see everything. Everything is nicely and perfectly scanned. And you can build your models. It's not a problem. Just print them. It won't take a long time, and then you can do anything you like. It's the same again. You get the emotions profile here, and you can keep the biology you tried to build after the implantation. Okay, this was a good choice, but now my first choice is I want to reduce the numbers of screwing on the implant. So my gingival healing abutment has to stay also for the process of scanning. So what to do? It's very easy. You see there's something changing. This is the healing abutment, and now we just click something on it. And the thing we click on it will transfer all the data of the implant. And this will reduce the number of screwings because we count again together. You bring in your implant, you bring in the gingival healing cap. Okay. You don't have to screw it if you bring your cap on it just for scanning. You have to unscrew it the first time when you will bring in the definitive abutment or crown. So just 2 times of screwing. And we saw in the literature that 2 times of screwing is nearly the same like you're using a one-piece implant. Means abutment and implant are the same. But the one-piece implant is a problem for me from the point of view of the emergence profile, because an implant is round. A tooth is never round. It's shaped 3-angled, rectangled, or like an egg. So it's never round. So this is the secret behind the emergence profile. Okay, now we're going on the other side. We keep the scan body. Yeah, it's the same. You drill in, you just measure. And in this case, we bring in the healing abutment, the scan healing abutment. So let it heal. In this case, you see, we used an Megagen, we got bone, we do the uncovering. In this case, we bring in these 2 abutments, let it heal, and then nothing to change. Just click something on. There's no screwing anymore. Just click something on. Do the scan. It's very precise. You see now. And then you can mill. It's another milling factory for models. Just want to show you some varieties. This is tooth, this is a tooth, this is an implant, this is an implant. You can combine these things. And this is the first case where you say, well, doing this without any model, you can do it, but will be critical. And the most important factor to use a printed model with lab analogs for implants is aesthetic. Because milled crowns are nice for the molar region, but not for the front, I would say. Okay, now you see the same case. This is the first time I unscrew this healing abutments. Bring in the abutments and everything is fine. So this is easy because it's 1 implant, 2 implants, maybe a bridge. This is your daily routine. But what about bigger cases? Just think bigger. Because if you know, or if you make the experience that with R2Gate, you are able to produce bigger cases very, very predictable and safely with the help of the AnyRidge implant and its stability in the bone, then you have to think about how can we scan these things. This was at the beginning. This is a prosthesis the patient is wearing. This is the jaw, and now you see we bring in these kinds of scan bodies, and we scan it. And now remember, I told you, it's difficult for the scan. The more distance between the scan bodies, maybe the precision will lose, or will shrink. It's better to say shrink than lose. This means if there is no scan body between these two scan bodies, it's difficult. And if you read some articles about the precision of scan bodies or intraoral scanners, they always measure 3 points, distance of 3 points in one jaw. This is the most important thing to read if you are deciding to choose an intraoral scanner for you. So if we scan this, the scan will be like this, and the technician now can do with his CAD/CAM software everything we want to create perfect teeth. And at the end, it's like this. Because in these cases, I wasn't able to augment in the height, so we used pink porcelain. It's not so ugly, I would say. I can recommend it to you sometimes because it's better than to have white teeth like this. And in the mouth, it's looking like this. So this is something the patient can live with. And you see perfect healed situations. And then you can bring everything very easily based on the CAD/CAM system. It's easier for you to do the intraoral scan than to do an impression in these cases. And if you've done impression in edentulous jaws on implants, screw it in, it's not a nice business. Okay, last big case, different kind. So these are the intraoral scans. Now you see 1, 2, 3, 4, 5, 6. Yeah, and I want to tell you a secret. It's easy to scan the lower jaw. It's easy to scan the upper jaw. But at the moment, I don't tell you the problem to scan the bite because there are no relationships. This is the lecture we heard already, how far he can bite. So we have to prepare something in the lab to bring into the mouth to scan first the left and then the right side. Because there's no system at the moment at the market available to scan, just to say to the patient, just close your lips, relax, and I will scan something, bring something on your head, and the bite is correct. No. You have to do it in a combination of traditional way and the future. For us, it's the present. It's not the future anymore. Yeah, for you, maybe it's the future, but for us, it's the present. So we're living in the digital world. So I call me a digital native because it's so fantastic to do these things. So the same again. Now you see the things from the technician. Hey, you can do it very easily. The model situation, you see these abutments. In this case, it's not screwed, it's cemented, just to show you different kinds. It depends on your strategy. I don't want to discuss this topic, if screwing is better or cementing now, because I'm just having 7 minutes now. But you see, this is a help to bring in the abutments into the mouth, because you have 6 positions. 6 positions on 6 implants means 36 possibilities to be wrong. Oh, no, not that much, but you know what I mean. So, this is very important. This is the bridge. So, you see, it's milled, it's veneered, it's perfectly. And in these cases, you can choose a material for the patient, because if you reconstruct a full arch in the upper and in the lower jaw, you have to look at the bite forces. And you have to choose your materials because of the bite forces. That means chipping is not a good thing because you have to remove everything. So you have to be smart by choosing or combining your materials. You see here? This is beautiful. This is something which keeps the gingiva alive. The bacteria don't like this smooth surface. They don't like it. They like rough surfaces. But here you're creating very smooth surfaces. So peri-implantitis can occur, yeah, of course, but it's not so easy anymore. And it's easier to clean. So this is very important for you to know. Okay, what is now our key for success? So many questions, so many new things. I want to give you something like a cookbook to take home message, as always called. Well, at first, if you have a look, you get an extraoral scan, you get an intraoral scan, you CAD/CAM design, model-free, model-based, printed analogs, milled abutment, fully anatomic, veneered. There are a lot of topics. I want to give you a little bit an order. The intraoral impression is determining the extraoral scan, but we don't have a look on this. The scanner, the intraoral scanner, is determining a little bit the intraoral scan. The CAD/CAM design is determined by the CAD/CAM software. That's quite logical. If you can do something model-based or model-free, it's determined by the software, by the model builder software you're using. Printed abutments in a model or lab analogs or no analogs is depending on your implant system. Because your intraoral scanner is scanning nearly everything. Your nails, your hand, your hairs, your eyes, everything. The intraoral scanner doesn't know that's a tooth or not. He's scanning. It's the implant system. The next thing, milled abutments, implant system depending. And fully anatomic or veneering, it's depending on the CAD/CAM software. So the most influence we got in this area of intraoral scanning is, no secret, the implant system. So the possibility for digital workflows is always depending on the implant system you're using. Because some implant systems, they have scan bodies, some not. They have lab analogs, they haven't. So this is very important. So what is now our key for success? It's a 3D X-ray examination as a base. You're starting. You're knowing what you're doing. It was perfect. I don't want to excuse myself in front of the patient. I have to do it at home a lot of time. Not in front of the patient. Because if I plan, I can tell him, well, this bone will be difficult, or it's easy. And I'm coming from Germany, and in Germany it's very difficult, the price. You know? In a country where we build Mercedes and Porsche, it's very difficult. And if you tell somebody it's very cost intensive, at the one hand, and on the other hand you say, well, it's an easy treatment, won't go together. So there should be a reason for this high or low price. Okay, digital planning of the situation in advance, not later on, in advance. This is very important, based on the scan, and utilization of 3D printing and milling for temporaries. I haven't talked about this topic. And the definitive. It's very important because milling and printing it's all over the industry. We're nearly the last to use it. And the last one is using an implant system capable for digital. That's the secret. That's the key behind all the pictures I showed you. I wouldn't be able to do these pictures if the implant system, the Megagen system I'm using, has no scan bodies. And with the opportunity to use a healing cap in combination with something to click on, I can reduce my screwing on the implants. This is very important. And with this message, I want to leave you alone. Thank you so much.